setting the stage for telehealth palliative care consults. And I'm going to introduce PETA in just a minute. Apologies to those of you who were with us last week. I am just going to do a brief overview of the initiative that we're working on in rural Washington, because I want those who were not with us last week to hear about that briefly before I introduce PETA. So first I want to offer thanks again to the Northwest Regional Telehealth Resource Center, which gave us some funding to do these webinars, to Northwest Rural Health Network, to my own team, and to Northwest Telehealth, who's our platform this morning, and to all the members of the Palliative Care Rural Health Integration Advisory Team who've been working hard on moving this integration of palliative care into rural Washington. The objectives of that initiative are to assist rural health systems and communities to integrate palliative care in multiple settings to better serve the members of that community in their own community whenever possible. We'll all be using a model for improvement where we test small-scale improvements, and at the same time, we'll be working on funding models for sustainable services. This cartoon gets at the why in sort of I guess, a sick sort of way, but you've got 6 months, but with aggressive treatment, we can help that seem much longer. It gets at the idea that often when we have a chronic illness, that there is no way to fix it, that health systems with the best of intentions and families and the patient themselves don't know another thing to do. And it's our sincere belief that palliative care does offer a set of things to do that are about healing rather than curing, and that can make quality of life better, decrease the impact from symptoms, and very importantly, follow the patient's own goals and wishes about what they would like. So that's the why that's behind this. This diagram gets at the idea that not all palliative care is hospice, all hospice is palliative care, but there's palliative care that moves upstream when people are living with a serious condition that's limiting their life and dealing with the impact on many facets of their life. There are ways that pain, symptom management, supportive care can be very helpful. This also shows that not everyone who has a serious condition goes on to die. There are people who go into remission or recovery, and then they're in survivorship. Both ends of that can happen when you're in that middle place. And it also displays that chronic condition or disease management is at the other end, and there are ways to screen and select patients that are appropriate to move into palliative care, because not everyone with a chronic condition meets that criteria. Our model includes direct telemedicine, case consultation regarding telehealth, which we're going to talk about today, both of those things I think, community engagement and education, working with the clinical teams on skill building and culture change. We hope to eventually build rural centers of excellence, and the whole time we'll be working on sustainable funding streams. But we are starting out with the things we know we have and doing what we can. Where this work is currently is that our advisory team has completed work on a conceptual model at sort of a high level, and now we're taking that into implementation planning and selection of the first 6 communities or so that are early adopters that we're going to begin with, and then we'll work to spread and refine this over time and hope to move it out to many more communities. We will be offering training that we think can be accessible to many of the rural health care communities in Washington, and not just those 6 as we move along this spectrum. Around telehealth in particular, our aspiration is to eventually be able to do direct telemedicine with patients and families in their homes, but we'll begin with a case consultation and training model, move into healthcare, sort of office-based or facility-based telemedicine, and then make our way to the home-based, hopefully at some point having all 3 up and going. So I want to introduce Pima, and then I'll get out of the screen and let her get in. We'll have a moment of transition for that. PETA is a registered nurse and educator with a clinical background in cardiac critical care, and she's employed currently by Providence St. Joseph Health, where she built and continues to develop the telehospitalist programs and supports regional efforts in Western Washington. She has collaborated with physician leaders to build over 25 distinct telemedicine projects over the last 6 years, and has trained over 1,000 nurses in telepresenting. So with that, I'm going to get off the screen, let you get on, and it's all yours.
Awesome. Good morning, everybody, and thank you for inviting me. I'm going to share my screen. Let's see here. All right. And I'm going to try. Can everyone see my screen? All good? Thank you for that. So I was invited here today to specifically talk about telepresenting and the applications of it, as well as identifying staff or members in the community who can act in the role of telepresenter. I'm not being paid by anyone to do this, but I was so excited to be invited and to be included in this conversation. As stated by Pat, I do work for Providence St. Joseph's Health. We're a large organization founded in 1856. I'm not going to spend too much time on these slides. It's just that we have a very large footprint across not only Washington, but across the western states. I believe we're in 7 states now. And that gives you a better understanding of our footprint. We're just now moving into New Mexico and Texas, which is exciting, and also in different more rural areas, which I particularly appreciate being in because I'm also from a rural area. I grew up in a very small farming community. Large facility, not going to get too much into the weeds on this one. And then this slide just shows the depth and breadth of telemedicine programs that are across our system. Most are regional programs, but there are 3 that are italicized are the system programs, and hospice is the one that I'm primarily responsible for. And so now I'm going to talk about being a telepresenter. So I'm going to talk about why this role was originally adopted. And when I was first brought into telemedicine 6 years ago, I was tasked with building a telepresenter training program. And to be frank, I didn't know what that was. All my experience was bedside nursing, and then I was a clinical educator after that, and I'd never heard of really telepresenting, let alone telehealth. So I did some research, as any good clinical educator will do, and I found that telepresenting actually has been around for a while, a good 20 years, as a matter of fact. Originally adopted in those areas of the country that really had a need for bringing patient care directly to the patient versus requiring them to travel long distances and oftentimes in what I would call adverse conditions, such as places in Alaska. As you can well imagine, in a small fishing village in the outback or in those outlying areas, trying to get into the major hubs is dangerous. It's a huge tax on the resources in terms of cost to even bring somebody in. And then additionally, oftentimes these people were very sick, and so they required family members to join them, which also created a real burden on the family. And then we won't even get into the fact that it was dangerous to travel. So Alaska was an earlier adopter, as was Wisconsin, interesting enough, Montana as well, and Georgia. And what they found is that they leveraged resources in the community to act as telepresenters because there honestly weren't any clinical resources. So in the very beginning, it was literally going out and training lay people very basically to take pictures and upload them into a file and send them back to the provider. The provider would actually read those pictures and then those still photographs and then make treatment recommendations. And then, of course, X-ray has been around for a long time where you've had people in different parts of the world that are actively reading X-rays and images during the daytime, but the reads are from folks that are during the nighttime. Anybody can act as a telepresenter, but I want to caution, I want to put some guardrails around this. So in my opinion, that you have to be careful about who you designate as a telepresenter, and it really honestly depends on what the requirements are, the clinical requirements are during the encounter itself, and we can get into that a little bit more detail. But if there is a clinical component where you're actually doing hands-on an exam in real time, then you need to really be careful about the skill set that that individual has who can actually be trained as a telepresenter. There really is training needs. You need to structure a program, and we'll go into that a little bit more detail. What to consider when selecting staff for this role, and I'll just lightly touch on that. Not only do they have to have certain skill sets, but they also have to have the ability to seamlessly work with technology, even when technology may fail on occasion, and to do it in such a way that they're not creating more strain or stress on the family and the patient. And then what to consider when starting a telepresenter program. So who? Honestly, it has everything to do with the protocol that's built with the program. At the very basic, you have a consultative model, it sounds like, and then it looks like you're going into hopefully next steps is going into a clinical setting where you can go into a facility where you're leveraging staff locally to act as a telepresenter for the provider on the other end. And that's where I think it gets pretty sticky in terms of who can be a telepresenter. If you're actually asking them to fire up a stethoscope and place it on the patient's heart so that the provider can listen to the heart and lungs, if you're asking them to perform even simple exam components, you need to be careful about who you actually target and designate. And I realize that this can be problematic because in a lot of regions and a lot of facilities, and even in major urban centers, resources are stretched really thin. So I'm not going to pigeonhole you and say it has to be a nurse, but I am going to task you with looking at your staff and really being deliberate about who you think could fit in this role and do it well. And do it in a way that's compassionate and caring and respectful, as well as can manage technology and to seamlessly move back and forth between the provider and the patient. Training is absolutely huge. As you can well imagine, throwing equipment at somebody without any kind of training and understanding is setting them up for failure, and it'll set your program up for failure. You really need to designate between facilitated exams and non-facilitated, and let me be really clear here. Facilitated exams are if you use any peripheral devices. Digital stethoscope is a good example. Non-facilitated is, am I putting technology in front of the patient, connecting the patient and the provider, but I'm not actually physically touching the patient in any way, shape, or form. Non-facilitated, you can train anybody to be a telepresenter. I spoke, when I was first starting out, I spoke to folks across the country because I needed to get more information on what this really looked like. And they, depending on what the needs were in the facility, the janitor was leveraged to roll in the technology, set it up, provide patient education, and then walk out of the room and close the door. And that's perfectly appropriate. Family is perfectly appropriate. It just depends on what the needs are for the patient. And you can do this in any place, in the home, in an acute care setting, clinic setting, any place that has a connection, and you have the ability to have a privacy. So obviously it needs to be a closed room, and making sure that there's no disruptions and that you can put in a secured connection, and away you go. I would recommend highly that if you haven't already, is to go onto the ATA website, and there are national guidelines specific to telepresenting. The ATA is a fantastic resource, and there's also a nursing SIG, which is a special interest group that can also answer your questions if you have further questions as you move forward with your journey on this. And this is just an example of some of the recommendations or guidelines that they have for not just telepresenting, but for starting any telemedicine program. And you'll see that home telehealth is there as well in the front. All right, so the role of the telepresenter really is to facilitate communication. And that communication is sharing clinical data. Did I take vital signs, and am I going to report those out to the provider in real time with the patient there? Is it saying, gosh, you know something, I noticed that the family member that's sitting off to the side is seeming upset about something that was just said or confused. And I'm going to make sure that the provider is aware that that is occurring, because their view into the room is limited. They may not be able to capture everything. And when you think about it, we don't really realize, being in person, how much we're taking in. And so in terms of just the feel of the room, as well as body language, and the telepresenter needs to not only be facile with the equipment, if equipment is being used beyond a video conferencing system, but also being facile in terms of relaying that information to the provider, making sure that the family and the patient needs are met, and that the provider is aware of what's going on in the room. And that's part of actually the training that's conducted. They have a lot of responsibilities. Typically, they're the ones that schedule the telemedicine encounters. They need to be able to be facile with the clinical and technical competencies. How easily can I transition back and forth between using a peripheral device and being able to assess strength, or touch, or pain, or anything along those lines. They need to be therapeutic in their interaction. It doesn't matter if they're a nurse and they are doing a hospice admission in the middle of the night, or if they're a EDRN that's facilitating an NIH stroke assessment for the provider in real time for stroke, or if it's a social worker that is interacting on the other end as the provider with the patient, as well as if they're just setting up the room and providing patient education. Because this can be a little scary. Typically, in our stage of development, I haven't run across many patients thus far that have already received care this way. And so being told that you're going to be receiving care this way, and I'm going to roll this great big piece of equipment into the room, and the provider is just going to appear, can be a little daunting. And it also may be, there's questions that are involved in terms of, gosh, are you going to record this? And am I going to inadvertently or discover later on that my exam is posted on YouTube because someone has hacked in? Or I find this whole thing really disturbing, and I don't want to receive my care this way. And those are all those questions and things that the telepresenter really need to tease out in order to be able to move ahead with the actual encounter. We always tell our telepresenters that a patient can refuse to receive care this way, and that's okay. And so they are given that option. It's very infrequent that happens. I'm thinking like in the last 6 years, I think I've seen that happen twice, over 1,000 encounters. So it's highly unlikely, but it can happen, and not everybody really takes to this. They also need to figure out, how are they going to communicate medical records? Is that even appropriate for the program that you've built? And if it is are they on the same EMR as you, or do you have access? Does the provider have access to that patient's EMR? Or are you going to have to figure out a way to send those records so that they can be reviewed ahead of time? And then they actually do the exam facilitation, whatever that means. If it's providing patient education, rolling the cart, or setting up the room appropriately, and then exiting the room after the provider is remoted into the session and confirmed that everything is working appropriately, then that's what happens. Or is it truly a full-on, hands-on facilitated exam? And then any follow-up documentation and scheduling. In a clinic setting, obviously, there may be follow-up appointments that need to occur, and actually on the inpatient side, there could be follow-up inpatient sessions that need to occur. So that could be part of their role as well. So the scope, and I touched on this previously, it has everything to do with what the exam looks like. What are the requirements for the patient to receive care this way? And if it is a non-facilitated exam, then you can very easily leverage a layperson. If it's in the home, and you have somebody that's end of life and you're really wanting just to connect with the family to help them, then you could set something up in the home and the family is their own presenter. Is it a setting where you need somebody that has some clinical background or expertise, then you will want to look at an MA or an ED technician or an LPN or RN, realizing that there are a plethora of roles, but also resources are very limited and scarce. And just trying to match up and marry that skill set with what the requirements are for the exam itself. Staff selection, like I said, is hugely important, and I want to do a little deeper dive in this. The non measurable skill in my mind is the emotional intelligence, and that is personally, I think, is probably the most important thing on this bullet point on this list. And clinical expertise obviously is also important, don't get me wrong, but if you can have a clinical expert on the patient side, but they don't have the ability to manage through when things don't go well, or they find that this is intimidating, it's not what they want to do, it's not how they want to give care in their community or to participate in, if they're easily alarmed by things, they're not going to be able to manage through and manage an effective exam. And it's not that they can't do it, it's just the atmosphere that they set will impact the patient's experience and the provider experience. Imagine, if you will, I'm the nurse and I'm having a really bad night, and I'm being asked to, or I'm having a really bad day in whatever setting I'm in, and I am bringing that into the room. And I'm setting up the equipment, and I'm muttering under my breath, and I'm acting annoyed that I'm even there, or that I'm acting stressed. You can well imagine that the patient will not have a positive experience from this. Whereas if I'm a nurse or the lay person coming in, and I'm calmly setting getting the patient settled, calmly setting up the equipment, I'm explaining what this looks like and what it'll feel like, answering questions if family are there, making sure that everybody's comfortable with the fact that it's secure connection, that it's not being videotaped, that their privacy will be maintained. They'll be able to have a real conversation with the provider, and the provider will be able to see and hear them in real time. Try to normalize it for them. Oftentimes I'll say things like, gosh, have you ever done Skype before, or FaceTime? It's very much like that, except it's clearer and secure. And then that seems to really settle folks down, and they actually, interesting enough, as things that I've been able to observe, is that they take to it really easily and seamlessly and appreciate having it and having access to care this way. But the presenter can make or break that experience, to be honest. So very good communication skills, obviously, and just being aware and self-aware as well. I think I've said enough. The training part, folks really, really appreciate a protocol, because then they know what to expect or what they're going to be asked to do during the encounter itself. And a protocol literally is, how are we going to share care of this patient? For the telehospitalist program, it's a full-on exam. And I walk through during the training not only how to set up the equipment, how they're going to communicate between the provider and them, but also what they're going to be asked to perform during the exam itself. For palliative care, same thing. When you get to that point where you're doing actual exams within the facilities, you will need to have a protocol put in place so that when you go out and conduct the training for the staff, and it could be really simple, right? It could be, We want you to bring the equipment into the room if it's not already there. We want you to set up the room in a certain way. We want to make sure that the family is present. We want to make sure that education is delivered. We want to make sure that questions are answered ahead of time. Anything that you feel is important to include in that interaction. And I don't know if facilitated exams are part of what you're looking at your roadmap, but obviously if they're going to want to listen to heart and lungs, anything like that, you would need to include that in the protocol itself. Underline again the patient and family interaction. I have to say I've been on the other end of palliative care, so I've had family members receive it, and I've been so appreciative of that. Typically, the caregiver that has been interacting with my family has been excellent. I have to believe that they will automatically bring that into the room, but if you don't have somebody that's been involved in palliative care previously, obviously really honing in on the family and interaction along with the patient interaction. It's amazing how therapeutic you can be through a screen, but there is some finesse to it. Case in point, we had a social work, telesocial work for my previous employer, and the social workers really weren't on board with this. They were worried about, well, how could I possibly be therapeutic online like this? And interestingly enough, we got some of them to try it. It was a need. They were, during the nighttime hours, putting on over 100 miles on their cars as they were trying to move in between facilities to provide services, which was not a good utilization of their time, obviously. Windshield time was huge. They were out of range, out of service, and so their productivity was certainly low and could not meet the needs of the organization. And once they actually tried using telemedicine, they actually found that it worked really well. And they were able to be therapeutic, and they were able to connect well with the patient, even if the patient required an interpreter. So at that facility, we needed to, interpretive services was also on a laptop. And so there would be a laptop and a cart, and it worked just fine. It worked just fine. So it's doable and proven to be doable. Also, be sure to include troubleshooting for the technology portion of the training, not just walking them through the workflow when things work perfectly, but also helping them if things aren't working well and they're having some technical difficulties. It gives them the ability to feel like they have some control. I also, but there are times that they're not going to be able to fix it. And so having a backup system where there's someone that they can call that can help them in real time. But that backup person will need to know that that person on the other end, the presenter, is comfortable enough to work with them to actually try to fix the technology in real time. You know, if they're flustered and they can't seem to hear what they're being directed to do, then that's not going to be helpful. So just having them not only touch the technology, but also walk them through some troubleshooting tips, I have found is really helpful and beneficial. And then caregiver etiquette. And I always include this as well, because I try to, when I go out and I do training, I try to set it up so that not only do the telepresenters are trained to what they're supposed to be doing, but I will actually run them through a mock of what the entire encounter could look like, and I pull them in and I try to put them in the provider place. Which gives them a great overview of, gosh, you know, they're having to work with the technology on their end as well, and it really helps set the stage for coalescing a great partnership. They have a better understanding of the things that the provider is struggling through, and I think will give the provider a little bit more grace when they see it from the provider end. I also will do that with providers. And we will run through an entire exam after I've done initial onboarding, and I will talk about what it will look like from their perspective. Also, I will give them tips on how they are looking on screen, and it's making sure that they can actually see how they look to the patient, because there have been times where the providers half of their face is cut off and they didn't even realize it. So giving them the tools, as you can see via this picture, you can see the provider can see them in the lower picture on the right hand side, and that gives them an idea of what the patient is seeing on the other end, so they can adjust their position. Lighting is huge. Making sure that wherever they're located, they've got good lighting. Making sure that they're HIPAA compliant, that they're not out in the middle of a busy unit, sitting at a desktop, having this conversation with the patient and the family. Make sure that they're in a closed room, that they can close the door and privacy is maintained. And I also, and this was not part of the ask, but I also run through billing. And billing is always a key point for these folks. And then I run through documentation and required documentation and any legal considerations for the provider. I don't believe I touched on that yet for the telepresenter, but documentation is required on their end as well. I always include, and this is based on national guidelines, that this exam was conducted via the AES encrypted bidirectional video session. And we do that because, not that this has happened yet, but in case there's a question legally where they feel there was a privacy breach, you can say in the charting, if it's 10 years down the line, how do you know that that you're on a secure connection unless you actually document it? And that's on the provider side. On the presenter side, we ask that they document what is used, and by that I mean, what peripheral devices have they been asked to use to assess the patient with? And in palliative care, if that's the digital stethoscope, then that's what they ought to, or anything else that you use, that's what you need to document. Who attended? So the name of the doc, the name of the patient. Well, the patient's already in the chart, but also who's the family at the bedside. And specifically, not just that the family was at bedside, but what their names were, if possible, and the relationship. So if they have a daughter, what's the daughter's name? If they have a spouse, what's the spouse's name? And the time of encounter. And the reason why this is really important is that it supports the documentation from the provider side. And once again, this is one of those things where this has not been an issue, but it's, gosh, if there's ever a question that this provider saw this patient at this point in time, you've got supporting documentation on the presenter end. And the whole documentation piece was confusing for me at the very beginning, and so we actually went and contacted folks that had been doing this for putting telemedicine programs in for quite some time and using the role of telepresenter for quite some time, and this is the documentation that's standard across the nation. This is just a scope of practice that I worked with the Department of Health in Washington to talk about telepresenting and telehealth with nursing specifically. It's still in flight. I keep looking at their interpretive statement to see if they've updated on their website the telehealth nursing piece. They haven't done it yet, but I will tell you that I've been in contact with them and they were supportive of this, and this is well within scope of nursing. And it has everything to do with using facilitated exams with nurses and the peripheral devices. Obviously, this is specific for nursing. And then considerations for building an actual telemedicine program. I'm going to just check my time real quick. you really want to collaborate with your internal and external partners. So what we have found is that leadership may be on board with this. I think that's a great idea, or you've got a champion in a facility that thinks this is a great idea. And but the rest of the staff, either medical or nursing or bedside staff, just aren't on board yet. And so if that's the case, then you need to get some, they need to do some work to help with doing a culture change, socializing this. It will make or break your program. And you could have everything fleshed out beautifully and have a great, powerful program in place. And if you don't have everybody on board that touches the program, you're going to have problems. Really, I recommend highly a program champion and to help facilitate that. Typically, it's a leader, and oftentimes folks are, because of the need, they are absolutely on board, but occasionally you run across someone that just isn't. And so that's one little checkbox that I like to tick off in the hopes of mitigating that ahead of time. Not always successful, but most of the time we are. Being sure that if you're putting in technology in these areas, that they actually can support it. And that's been a big issue as well for us. You need a certain amount of bandwidth, and I'm not a technical person, for lack of a better word, to be able to accommodate the amount of data that moves back and forth during any kind of video conferencing session. And if you don't have that kind of bandwidth or reliable connection or network, then you're going to have ongoing problems, which is very disruptive to the program, as well as to the patient and the family. I mean, it could be very powerful, and yet if it's constantly you're freezing, your video's freezing, or it's shutting down completely, or you can't hear, it really negates the whole point of the program. And then you've got, which is not what you want to do in palliative care at all, and it absolutely will block your ability to be any kind of therapeutic presence. Managing resources, and that's all about determining who can act in that role depending on what's going on with the actual protocol and program itself. Who touches it? Who are you going to need to rely on? Is it multiple staff members, depending on the resources and who they identify, to set up the room versus go in and facilitate the exam if there is exam, or sit by the patient's bed, or sit in the room and help facilitate that conversation. It just depends on what the resources are in those facilities and how they want to input the program. And those are my references and resources. And I'd like to open it up for questions if anybody has any questions. I'm a little bit ahead of time, not too bad.
Hi, Peter. This is Jack. And I know you just briefly touched on billing, but in general, wanted to know if there are models that support payment for both the telepresenter and the provider, and how that might work.
That's a good question. So there is a facility fee, and I believe it's, gosh, I want to say it's like $35 that you can actually charge from the facility perspective that will, I don't know, I'm not saying it'll cover the cost of a full-time telepresenter, but you are able to capture those fees. And then also there are pro fees that you can drop from the provider side. You know, some social workers are able to bill. Obviously, providers, nurse practitioners and medical providers are able to bill. It honestly depends on where the facility is located, based on the CMS requirements. The interesting thing about that is that initially CMS was very strict about what could be determine, particularly in Washington State, what you could bill for. And my understanding is, and I'm not an expert on billing, but my understanding is that Washington State in the last couple of years have it put forth legislation and put in place legislation that will actually allow for a more comprehensive billing capability in terms of they look at telemedicine as the same as in person, and you can bill insurance companies as well as Medicare and Medicaid for telemedicine appointments. What I'd like to do, Jack, is actually get you into contact with Lisa Roach, who is our billing specialist at Providence for telehealth. I'm fumbling around trying to, full disclosure, trying to give you some information, but she would be able to answer your specific questions.
That would be fabulous. Thank you.
Yeah, absolutely.
So Peter, this is Pat. We analyzed that bill, and it indeed did open the doors, and it also opened the doors for home as an originating site in Washington. And then this last year, they tweaked that slightly, and they added or a place of the patient's choosing. I actually was talking to a Providence home health agency last week, and home health agencies seem largely unaware of this option at this point. I just wondered if in your travels, if you'd heard anything in the other states or of anybody working with the home site, with home health or with family, and what your experience of that has been.
Yeah, unfortunately I can't answer that. In my travels, I'm very specifically honed in on the inpatient side, and I'm not an expert in any way, shape, or form on what's happening in the home health space. What I can do, Pat, is once again, I'm going to refer you back to Lisa Roche, and I think that she would be an optimal person to schedule a phone call with, maybe with Jack, and so that you can get the answers to your questions. We are looking at Providence and going into home health. It's certainly a huge need, but I have no knowledge about that, unfortunately.
No points off, and thank you.
Thanks.
So this is Tammy from Northwest Telehealth. I just wanted to add also that my understanding as the bill for 2018 will allow for a reimbursement payment into the home for Medicaid and many of the private insurers. That does not include CMS at this time. So at this time, CMS still mandates that origination site is more like a clinic or a hospital, and not into the home. So we're hoping that that will change as well, especially for palliative care patients.
Agreed. Fingers crossed that that really does happen.
Peter, this is Tammy again. And I also wanted to maybe have you talk a little bit more about the telepresenting from the provider perspective, because for what we do in telehealth is a much more ambulatory care, where maybe a nurse will come in and do vitals, get everyone started, and then leave the room. So I think that the degree of training for the provider to be able to manage that even in the home setting is probably more important than the person or the nurse who may be setting something up within the space for that.
Right. So we try to loop in the providers as closely as possible in terms of, what are their needs in the home, and not knowing palliative care in the home setting at all. My experience has just been somebody that's come in and done an assessment, so I don't know if a provider is going to want an assessment by a clinician or not. But we really partner closely with those providers, figure out what it is, and that's where the protocol comes in play. Figure out what it is that they would like to accomplish during their visits, and really walk them through the process so they get a feel for what it will feel like. Because as you can well imagine, they're not always receptive either to this, to be frank. oftentimes it's, well, how can you possibly do an evaluation? I went to medical school for 4 years and my residency and all of that. How can you possibly train anybody to do this? And secondarily, I really feel this will impact my ability to therapeutically interact with the patient themselves. And the only way I have found to manage that conversation is to show them. And then their eyes brighten and they light up and they go, oh, okay. And then they really honestly will work and partner with you very closely and kind of play with how far can we really go with this in terms of, gosh, I want to listen to the heart and lungs, but God, I really would like to do a skin assessment as well. So I show them what that looks like. Oh, I guess I really do want to add that to my protocol. Those kinds of things are huge, and that's really foundational. In the meantime, what they don't realize is that I'm actually training them on how to use the equipment and how to interact with a telepresenter at the same time. And I will remind them that it's their exam, it's their evaluation, their assessment, and they need to, not only do I need to understand what you're going to ask of me, but if I'm doing something wrong, or if I'm blocking your view, or if the placement of the patient isn't appropriate, then you need to let me know. And so we walk through all of that. And then I also say, gosh, something, the way you're sitting, you're rocking back and forth. And when you're rocking back and forth, the screen, the video is going in and out in terms of focus. And that's really affecting my ability to interact with you, and it will affect the patient as well. And so giving them in the moment, real time feedback on how they're looking, how they're talking, if they're moving their head off to the side and I can't really hear what they're saying, I'll correct them. And just getting them comfortable in terms of what it means to interact with a patient and with a clinician or whoever, the family, via this screen. And interestingly enough, I have learned that providers are trainable. They are really smart people. There's a reason why they got into medical school, and they really they ask great questions and are very intent on doing the best job they possibly can, and because they're all about the patient too, right? I think everybody that comes into this field is, how can we leverage technology to the best of our abilities? And so it's a little less structured for providers. But I do run them through how to set up the technology, what they look like on screen, run them through what a exam will look like, make them dial into an actual piece of technology, whether it's a desktop, a laptop, or whatever, what they would have on the other end, so they get familiar with it, because they don't want to look clunky in front of a patient either. And then walk them through what the workflow is. This is how you're going to contact them. This is how the patient or the family or the presenter on the other end, depending on the location. This is how it's scheduled. If you're running late, if they're running late, this is how it's going to be coordinated between the two of you to let each of you know. And that's what we do. It's very detailed. Did that answer your question okay?
Yes, thank you very much. Well said.
Peter,
I can imagine that this is a team sport, right? Because
it is.
You could have a patient and family on one side, and then with palliative care, you could have an interdisciplinary team in that clinical role. So you talk about multiple people on both sides of the interaction, what that might look like.
So when you have multiple people on both sides of their interaction, it's almost as though if they were standing there in person. That what you need to let folks know is that if they can't talk over each other, because then it will actually create what's called clipping in the audio portion, where you will not be able to hear what the other person is saying. But think of it as though you are on rounds and you're in a circle and you're all having a conversation, whether it's with the family and the multi-care disciplinary team, and the person is there that's logged into the session, and they're standing there with you, but they're just happen to be on a computer screen. So just as though you were I guess what I can't state enough is it's as though you're there in person. You just happen to be on a screen. So I the interaction, I think, is very normal, and I don't anticipate that it'd be any different than if I was in a multidisciplinary discussion with folks standing there in person. The big thing is that you want to make sure that whoever is participating is situated so that they can be visible by the person that's actually remoting in, as well as they can see the person that's remoting in.
Actually, I had the exact same question, and was curious about how, from a telepresenter's perspective, how you sort of make sure the room is going to work for the provider.
Right.
And
So
how the people are arranged and all of that.
mm-hmm. So typically you've got the patient, and if the patient's in a bed, I ask the family to be at the head of the bed by the patient, and the presenter will be on the other side, and the technology is set up at the foot of the bed, usually about 18 inches away, but it really honestly depends on the equipment. If you're on a laptop, you could put it on the bedside table and just put it right there up close. But you really want to do it so that the patient is grouped, or the family is grouped around the patient, and the presenter is there. Oftentimes, and I'm just reflecting on the times that I've done telepresenting, I will stand up by the head of the bed on one side, and if there's a family member, I'll have them sitting on the other side. The cart's at the end of the bed, and I make sure that I'm not blocking the view of the provider at all, but I'm participating. And it literally is, I'm standing there participating, and when I'm asked to do something or asked a question, then I either execute an exam or I respond to whatever the question is.
So taking that into kind of concrete terms, in Zoom, I know, and in some of the video conferencing equipment that Northwest Telehealth had, the person who's speaking, the camera would go there. But in the telemedicine equipment, not necessarily so. It's going to be a fixed view that you have to get arranged, sounds like.
You do, and it depends on your equipment itself. And I didn't really touch on the equipment because I really wanted to hone in on the role itself, and not knowing what kind of equipment you're going to put in. But some of the equipment that we use is actually a cart, and a cart it's a PC on wheels. It's got a great big screen, and then at the top it's got a camera, and the provider is able actually to manipulate that camera. And you can pan, you can tilt, you can zoom in on the patient, look at pupils, do that part of the assessment, zoom out. You can pan over and focus in on the patient or on the family members if they're asking a question, or you can pan across the room and talk to that multidisciplinary team. Honestly, it just depends on what types of equipment or technology you're going to put into place. And you're right, Zoom is locked in position because you're using the video camera, or at least I am in my laptop, and that's not manipulable. But for some of the technologies, you can do that.
And thank you, Peta. And this is Tammy with Northwest Telehealth. Most of the software for video conferencing has a potential for pan, tilt, zoom, like Zoom does, and the software that we're on today. The really determination of whether it works or not is the remote site camera. So, for example, my camera has the ability to pan, tilt, zoom, which means that you could do it from your location. But if you're going into a patient's home and they're using a laptop with a fixed camera in that laptop, as the provider, you would not be able to pan, tilt, zoom it because the technology in that camera is not available. So it's more, again, a function of the camera and the computer than it is the software.
Exactly.
Pat, this is Leslie Emmerich. We've got David Bucher and Candace Cheney on the line this morning, who both have palliative care programs, and I'm wondering if either of them are using telemedicine in any way yet in their programs. So I'm asking David and Candace to speak up if you are.
And you may need to click down the bottom corner of your box to unmute. There should be a little microphone symbol that you can hear.
Thank you. This is Candace. No, we aren't using it at this moment in the Washington State area. I know we've got a pilot, I believe, happening in some of our other areas. But of course, the biggest question and challenge I can see is because we are serving rural patients, their internet, their bandwidth, we have challenges with that even in just some of our rural communities, let alone into their home areas. Have you dealt with that yet or experienced much of that technological challenge in the rural setting?
This is Pat. I can also respond to that. In Georgia, where the entire state, many rural areas were using ports to go up to a HIPAA-compliant cloud space together. They were just bypassing broadband in that situation.
Thank you. That's great.
And this is Tammy from Northwest Telehealth. I think our success so far with doing anything into the home or into where a patient, I don't know, even if it's an educational program, we have basically set up a patient certification program where somebody could contact us and test their ability to receive care virtually or to participate in a program. And that's not only assessing the bandwidth that they have, but then also talking about what kind of technology, do they have a camera, a microphone, and what kind of hardware they have in the home. So we start out with saying, here are the requirements. If you'd like to test prior to receiving services, what's nice about that is that then the provider and the patient are not dealing with technology at the time of the consult.
And we often look to Alaska, right, because they invented rural. On the Northwest Regional Telehealth Resource Center website, there are links from their last conference to the Alaska presentation, and they're dealing with incredible holes in access for broadband, of course, and they have a dedicated role that does just what Tammy's talking about, where the day before they're going to have the interaction, that person tries to get in touch and basically sort of tries everything, either through smartphone, and sometimes they end up with just a telephone feed and no visual, but they do everything they can to get the visual going as well. And it's a lot of troubleshooting and good humor, from what I understood, to really work with the family and patient to see what they can establish. But there's a dedicated person to work on that. Well, I'm noticing we have about 2 minutes left. Is there anybody else that would like to ask a question before we wind up?
David Bucher is trying to get into us, but he sent a chat saying he can't be heard on the phone for some reason. Says we are a home-based palliative care and currently not using telehealth. We have bandwidth problems in the community also and cannot connect for certain rural areas in our geography.
There's a really interesting opportunity, and I make no promises about what it will mean, but first responders, there's been an effort to create a dedicated network for first responders in the state. And I recently hooked up Doris Visea from the Home Care Association of Washington with the person, Shelley Westfall, who's managing that for Washington, to ask whether home health, being out in remote areas, sometimes in medical emergencies, whether they might be eligible to get into that network. So that's being explored. And I know that they had this incredible map where they're showing where the holes are in access in the state and working to close those as part of that project. I don't think, you know, they're going to get to every remote mountain peak in the Cascades, but I think they're really looking at how to close the gaps where people are living. And so I think more news at 11 on that and how that develops. But it could be a boon to home health. Well, I'm a start on time, stop on time kind of facilitator. So any last comments before we thank Peta? Sorry, I keep looking up. I have this bad arrangement in my room here. Okay. Well, thank you. I'll try to look in the camera this time. Thank you all very much for joining us. And there'll be more to come, and we'll put news out as we have offerings available. And thank you very much, Peta, for sharing your expertise with us this morning. A good day to all.
And thank you.
Thank you so much, Peta. Thanks, Pat.
Thanks,
Thanks,
Peta.
Pat.
Thanks, Pat.
You know.